Thank you. Thank you, one and all. And welcome to our 50th Peculiar Case Series in Renal Transplant monthly meet. Actually, it is a special meet because it is our 50th meeting. And we have been doing this for the past 4.5 years at the time of peak COVID. And we had a small idea of creating this group. And now it has grown up to the level of having a lot more than 100,000 nephrologists in our group and having a pan world representation also. And this meeting, I take an opportunity to thank the participants, the speakers, the panelists, and for giving us unwavering support for the past 4 years to make this meet a very grand success. As before, this meeting has 2 presentations by a very good, eminent speakers, paneled by a equally academic and one of the we can say as a stalwarts in nephrology. I am very much happy and pleasured and respect to invite Dr. Edwin sir, who happened to be my teacher in DM course. And he's no doubt he's an inspiring teacher, and he has inspired many of the MD students to take up nephrology as their career. Teacher is one who doesn't teach, actually. He will inspire you to learn, and he's one such kind of character who inspires young budding brains to take up nephrology, and he inspires you to read and involve into the thing. And he made Stanley as one of the premier institute to pursue DM nephrology course. And all over India, people know him very well, and he needs further introduction to the audience. Welcome you, sir, for this meet. And you will be the...
Thank you for those nice words. Thank you, Rajan.
And Shyam Bansal. He's a person of multitasking, clinician, transplant nephrologist, director and head nephrology of Medanta, and also sharing a burden of a secretary of ISN, and he's doing a wonderful work, multitasking work. And this podium, this forum, or even any other forum doesn't need his more introduction, because he's a lively person and he's academically oriented, and he's doing a very good job in all of his spheres verticals. And he had been supporting our group for the past 4.5 years, either with his presentation and by sharing as a panelist. And thank you for your support you have rendered for the past 4 years. And you are the fitting person to be in this meeting, because since we have 2 important renal transplant infection cases, and you are the one who edited a transplant infection book, and which was going good around India and popular among the transplant nephrologists. I'm sure your presence will give more insight into the discussion and will make the discussion lively. Welcome, Dr. Shyam.
Thank you, Rajan, for inviting me, and it's really a pleasure to be here. And you are doing a fantastic job, and always support.
Thank you, Shyam. And I'm very much pleasure to invite Dr. Ram, who is going to present a first case. And from what he conveyed to me a short for this presentation, I'll be wondering how this patient survived, actually. And you must be having a torrid time dealing with this patient, and it's going to be really interesting. He's known for an academic work and presentation. His presentation skill is awesome, and I'm sure that audience will be experiencing such kind of presentation. And Dr. Ram is being the director and head of nephrology, SIMS Hospital, Chennai. He's doing a lot of transplant work and extracorporeal service also. He's more interested towards that, actually. And Dr. Ram, welcome to this meet, especially our 50th meet. We're looking forward for your talk. And I'm very happy to invite Dr. Dhananjay, who happened to be my contemporary. He did his DM from IKDRC. We happened to meet him during our PG days at my special posting to IKDRC. And he's a voracious reader and a hard worker. I never see him sleep at all. And his insights and his comments over the topics are very much sharp and crisp, and he's a soft and silent spoken, but he has a lot of rich knowledge about transplant. And he's a very good transplant nephrologist, as consultant nephrology at Continental Hospital, Hyderabad, doing a lot of transplants and high-risk transplant. And today he is going to share his experience on hepatitis B positive donor to hepatitis B negative recipient. And I hope both the session will be enlightening and going to be having a good academic phase. Without wasting further time, I invite Dr. Ram to start his first presentation.
Thank you, Raj, for your nice introduction. And thank you for, it's an honor actually to be here to present in your fifth peculiar case series. I think I have at least participated in 5 of this, almost 10% of your meetings, either as a panelist or as a chair. I think it is the third presentation I have in this meeting.
Definitely, Ram. Definitely.
So this patient, we struggled a lot to manage. How we pulled through, as you said, is mainly because 2 things. One, the patient and family trusted us fully, and the second one, the cost was not at all an issue. You might be wondering, I mean, by the end of the presentation, you might be knowing how much you would have spent in a corporate hospital like ours with these kind of problems. So this is a polymicrobial infection in a post-renal transplant patient. It is usually a microbiologist treasure trove. You know, they actually came behind us looking at why this patient is having these kind of growths. What are you doing about it? And it has been a nightmare for me to manage this patient. So I would be sharing this experience and my learning points in each and identifying each and every infection. So this is transplant done elsewhere. So the first few details, whatever I'm going to give, is from the discharge summary from the previous institute. He's a 56-year-old man. He's a hypertensive for the last 8 years. He was non-diabetic. Please note that he was not a diabetic. He presented elsewhere with the CKD and in 2019, as usual with most of our patients, when we say there is not much of a cure possible, he went into an alternative medicine. Then, as usual, he progressed to end-stage kidney disease. By the time he again presented, he was in end-stage kidney disease, and it is presumed to be chronic glomerulonephritis. He did not undergo any biopsy. Kidneys were shrunken. And he was on dialysis almost close to a year, from December 2022 to 23, and he underwent a living donor kidney transplant in November 2023. In the pre-transplant period, he had recurrent hospitalization with shortness of breath. In fact, he underwent even an angiogram for that matter, which had minimal CAD. Then they did a chest CT imaging, which showed gross pleural effusion. They did aspiration of pleural fluid, and they went ahead with CT-guided pleural biopsy also, which showed features suggestive of pleural tuberculosis. The gene expert from the tissue was positive, and the biopsy is also showing granulomatous inflammation. He was started on ATT as usual. 2+4 is the regimen they followed. 2 months of 4 drugs and another 4 months of 2 drugs was the one which has been given by the primary nephrologist. Then the course was completed in 6 months' time. And he was started on pre-transplant workup subsequently after those 6 months. But he continued on those 2 drugs just before transplant. So this is the data, whatever we could get from his previous hospital details. He had a history of blood transfusion once long ago. And the immunological profile had 1/6 HLA match. Pre-transplant cross match was negative. CDC was only done. There was no flow cross match. There was no single antigen bead testing or DSA testing that was done. There is no PRA also. So they just did a HLA typing, then a pre-transplant CDC cross match. That's it. The CMV workup showed D+R+ status. The donor was a 33-year-old female, and it is an ABO compatible transplant. So this is the basic details, whatever we could get. So he was induced with basiliximab there, and he had a DGF. The maintenance is usually the standard triple immunosuppression. He had a very stormy post-transplant period as per the available records. You can see he had hemodynamic instability, oliguria, requiring CKRT in the 3rd postoperative day. Thereafter, he had graft dysfunction with progressive increase in creatinine. He underwent 2 dialysis sessions on day 7 and day 9 after the CKRT, which was run for 48 hours. And on the 9th day, a biopsy was done. And the biopsy showed acute tubular injury, obviously with very high dose tacrolimus. So the tacrometabolic phenotyping was not done. So he had very high tacrolimus level all along the hospital admission, and the biopsy showed acute tubular injury. This is the prior data. So he reached nadir creatinine around 1.5. They have removed the DJ stent. He had a very good urine output, and he was started on co-triamoxole prophylaxis alone. And they have continued on triple maintenance immunosuppression. This is in January 2024. Note that. Then the second month post-transplant, he presented, he had, I think this is, okay. So this is the presentation to us in March. This is the presentation he had earlier, 2 months post-transplant. He had progressive, again, graft dysfunction. They had CME quantitative PCR, and that had some 2,300 copies. Thereafter, they started on valg encephaloprophylaxis. Prophylaxis. So it is not a preemptive or a prophylaxis. It is the deferred prophylaxis after the patient started to have some CMV PCR, some CMV in the PCR. Then to us in March 2024, this is the first presentation to us. He had just crash landed in our OP, in our emergency with diarrhea, shortness of breath. He gasped, he was gasping, he was intubated, he had respiratory distress, he had a graft dysfunction, and the all routine stool, blood tests, everything done, which had all showed initial tests may be negative. He was resuscitated with ventilator support, CKRT for acidosis. As usual, he was given like a shock treatment with inotropes, vasopressors, fluids, and broad spectrum antibiotics. The initial workup for diarrhea was negative, but he continued to have diarrhea. That is why we proceeded with endoscopy and colonoscopy under general anesthesia. This is the first admission. Okay, so this is the endoscopy colonoscopic findings. You can appreciate the endoscopy showing a lot of oral candida, and the last figure being showing a sigmoid ulcer. So biopsies were taken from either one. So this is the finding in the sigmoid ulcer. We know that is very florid esophageal candida. Everyone can easily pick up, and this is the cryptosporidium, which is there in the intestinal epithelial cell. Despite stool routine cultures, nothing did not show anything, but the biopsy showed a cryptosporidium at the intestinal epithelial cell. So to review basically the literature about cryptosporidium in renal transplant, we had a recent publication from Osmania. You can see it is a retrospective study involving around 60 patients. You can see up to 30% had cryptosporidium positive. That is very interesting. You know, almost 30% of our post-transplant diarrhea is cryptosporidium as per the data. Many of them had the other risk factors like using thymoglobulin as an induction. They had prior hospitalization, graft dysfunction, co-infections. And it is very important to note that the response to monotherapy in these patients is only 27%. And many of these people will need combination therapy. And please understand, almost 72% of them required more than 4 weeks of therapy. Many of us stop very early your nitazoxanide, especially with cryptosporidiosis. So many of these people will need combination therapy. Many of them will need long-term therapy. And there is a significant risk of relapse around 12%. This is the published data on cryptosporidiosis. So again, about treatment of cryptosporidio in solid organ transplant recipients, you can see it depends on how severe is this disease. It in mild to moderate cases, you may get over with monotherapy with nitazoxanide for 14 days. Whereas in majority of cases, when it is severe, they need combination therapy. And as I said, in some patients, it can relapse. So in relapsed cases, you have to use a combination therapy of 4 drugs. They have used nitazoxanide along with fluoroquinolone, cotrimoxazole, and azithromycin. Such a big combination is needed in patients who are refractory to your initial treatment. This is about treatment of cryptosporidial diarrhea in solid organ transplant. So what I have learned from the initial presentation and the review of literature, cryptosporidium is more common than what we think. In the published data, it says 30% of post-transplant diarrhea. Review of literature says somewhere around 20 to 30%, depending on the data we cited. In addition to identify in some patients, because many times stool testing may miss, there are emerging techniques like antigen detection and molecular methods, but still the gold standard appears to be the stool testing. Many times it is a part of mixed infection. Many people have not only cryptosporidiosis, like what I have mentioned in our own patients like Candida, it's often a mixed infection. And understand that many times it requires a longer course of combination therapy of multiple drugs. It has a tendency to relapse, that also we have to watch for. This is from the learnings from the first presentation about cryptosporidiosis.
Yeah, Dr.
About
Can I make a point, because this is a very important actually infection and very relevant to Indian transplant patient, cryptosporidia. So the important that we also had more than patient data, more than 100, and prospective trial. We have seen more than 20%. And obviously the relapse, the important thing to treat this infection is you have to reduce the immunosuppression. Unless you reduce the immunosuppression, it's not going to get better, because as soon as you stop the medicine, it will again relapse. And secondly, combination, not all 2 or 3 drugs. You can use nitazoxide with azithromycin, that is a preferred combination. And in immunosuppression patient, you have to give it for they say 2 weeks, but most patients will require 3 to 4 weeks of therapy and reduction of immunosuppression. Without that, it's not going to. And then for prevention, it's important that people take boiled water, because unboiled water, this is, even if you take the RO water and all that, this is not destroyed, and that is why this is so common in Indian patient. So I just wanted, because there are multiple infections, so I thought I'll just tell my experience.
So many times it is the food handlers that are the source for this infection also. And as you said, drinking water is supposed to be another source that is also there in the published data. Yeah, reduction in immunosuppression is important, especially with severe infections, because that also I have mentioned, because want of time, I did not go in much in detail. Coming to the second infection the patient had, we know the Candida is the most common fungal infection post-renal transplant, and esophageal candidiasis is considered as invasive fungal infection. Many people think like it is like a skin infection. They may just ignore the severity of esophageal candidiasis. Many times people will need azoles, but the problem in azoles in kidney transplant is they have a huge interaction with CNI. So many times we need to monitor the tacrolimus levels. There are group of Candida like Labrata which have intrinsic resistance, that also we need to know as clinicians before choosing the drug to treat Candida. The echinocandins are the alternatives for Candida esophagitis. They are expensive. So if you look at the comparison between solid organ transplant and hematopoietic stem cell transplant, you can see the left side, you can see the solid organ transplant. The common is Candida, Aspergillus in the order of the frequency. If you look at the hematopoietic stem cell, Aspergillosis dominates, second only to Candida. And for unknown reasons, because of universal prophylaxis, I think the PCP has gone to the last. So this is the overall prevalence of fungal infections. And it is very interesting note the timelines of these fungal infections. This is another interesting observation that has been published. You can see something similar to your Rubin's tape, this one, infection calendar. We have fungal infection also, there is a timeline. If you look at the first few months, it is due to the contamination of sites. Mucor is the one that comes, the orange one. The second one is Aspergillus in the first 3 months. Candida comes, but it is a typical opportunistic infection between 1 to 6 months. Thereafter, the mucorales dominate. From there, the other species takes over. So just to make it interesting that in this patient, which we are talking about, had in the infection around the 3rd month. That's what I meant. So it also follows that certain pattern in post-kidney transplant. So this patient, we did a CME PCR, which was negative because he had a diarrhea and all, antibiotics, and he had a persistent diarrhea. We have already withheld MMF. He was without antimetabolite for quite some time. Then we switched over to azathioprine. Obviously, he was put on antifungus with frequent monitoring of tacrolimus levels. We did treat with nitazoxanide. Slowly, diarrhea settled, graft function improved, and creatinine also had slowly settling down. That was the point. But he continued to have persistent odinophagia dysphagia. Again, repeat endoscopy showed candida lesions persist. So he was switched over from fluconazole to micafungin. For 2 weeks, he received IV injection and he had a symptomatic improvement. So it is the second admission. So this is about the first 2 admissions. The important point here is the candida esophagitis, which is refused to go down with fluconazole, and we were forced to switch over to micafungin also. So that's the first admission. This is the second admission. This is just a month later. Every time he used to crash land, and this time with fever and fatigue. He was resuscitated as usual, but this time with non-invasive ventilation itself. Urine culture showed ESBL E. coli. He was treated with meropenem followed by ertapenem for almost 2 weeks duration. This is a classical urinary tract infection. Thereafter, the story expanded further. He had persistent pancytopenia following this episode. We were initially thinking it is due to the carbapenem-induced bone marrow suppression. His counts used to be 2,000 persistently, sometimes even go to 1,000, even in triple digits at times. So we were kind of initially thinking, considering this, we have to continue carbapenem. We kept on continuing. But he continued to have pancytopenia. So again, started developing another constitutional symptoms. He was started having low-grade fever, weight loss, vague abdominal symptoms. Because of pancytopenia, hematologist was called. We did a bone marrow, which showed hypocellular marrow. We couldn't identify any viral inclusions. He did undergo a repeat endoscopy and duodenal biopsy, which showed CMV duodenitis from the biopsy. We did pick up from the duodenal biopsy specimen. The PCR showed a significant amount of CMV. Again, he was treated with IV ganciclovir followed by oral ganciclovir for quite some time. It was continued actually. So this is about the second admission. The record review, I told you, this patient did not have primary prophylaxis. He was not given thymoglobulin despite having HLA mismatch. He had a D+R+ status. So this is the data which we could get from this. So whatever I have learned from this CMV incidence is, CMV is still common especially without prophylaxis in our patients. And the incidence in D+R+ from the literature is 4 to 7% without prophylaxis. Diagnosis can be missed, and sometimes when you just do a PCR from the blood, tissue PCR is a value addition. When you have very high index of suspicion, when you can do a tissue PCR also. And nowadays with the universal prophylaxis, the onset doesn't limit within that 1 to 6 months. Many times it goes very late. And nowadays, we have to look for ganciclovir resistance by looking at these things are available nowadays. The drugs are not available, but in the worldwide, there is approval for ganciclovir resistant CMV. These are all basically, I have put it as a learning points from the infection part. There are some publications regarding why tissue PCR should be done in patients with CMV disease. There are many times, especially these reports are there more in hematopoietic stem cell transplantation, where we may miss the CMV infection. So that is the learning point about the second admission. Third admission is more dramatic. He developed a blister at surgical site a month down the line. We did get a surgical consult. The surgeon just opened up the blister. We did a CT that you can see the subcutaneous plane. You can see the changes here in just above the graft kidney. There are subcutaneous phlegmonous changes. And we did aspirate the pus, which showed Pseudomonas. Again, it was a pan-sensitive Pseudomonas. We don't know whether it is a colonizer there. He was started on ceftazidime and the wound started healing. This is the third admission. But a month down the line, he developed a profuse discharge from the wound side, which was mucopurulent, and wound gapping started. and the CT showed a sinus tract formation with surgical site infection. So this is where it opened up very big. You can see the wound becoming very big. And that is the mood we had. Oh, so many times we see this again, and this again showed. You can see now, not only there is a subcutaneous collection, the collection extends down, lower down here, just above the graft kidney. You can go down, it is going down inside. So surgical consult was obtained, and we did have a debridement. The smear from the fluid there showed sheets of AFB. Gene expert is negative. I'm sorry, I mentioned it wrongly. Gene expert is negative, but it had a sheets of AFB. The culture showed NTM, Mycobacterium abscesses. So we did get this patient along with infectious disease with clofazimine, doxycycline, and clarithromycin. That was the initial treatment that started for Mycobacterium abscesses. This is the sequential wound status. You can see after initial debridement, some back draining, then finally we could close the wound. This also we thought the end of the story. We kept on continuing those 3 drugs for NTM. That is the data about NTM. So just briefly go through NTM data. There are almost 140 species are there. Generally, they are environmental organisms. You can see in general population, they are considered uncommon causes, but it appears that there is a population-based US data. There is a skin and soft tissue infections due to NTM is going up, more so in solid organ transplant in recent years because of increasing exposure and increased methods to diagnose them. And among solid organ transplant, lung transplant patients appear to be very high risk of NTM disease. So this is how we classify the NTM. You can see from the slow growers to rapid growers to photochromogens, cotochromogens, our age-old classification. Our bacteria, which we isolated, is from the rapidly growing species Mycobacterium abscessus. Coming to the pathogenesis or the prevalence of these non-tuberculous mycobacteria in kidney transplant alone, you can see the commonest is Malmoense. That is the commonest species, and abscessus comes number 4. This is the order of frequency which is reported in literature. The risk factors which I have already spoken. So in general, it is in our patients, in general, it is the environment that makes. So it is due to the soil, the water, the contamination during the procedures. That is the source for most of our the NTM in transplant. Coming to presentation of NTM, NTM usually presents as 6 parts. It can present as lymphadenopathy, it can present as skeletal problems, it can present as skin and soft tissue, it can present as pulmonary, it can present as disseminated infection, sometimes a central line infection. So 6 common syndromic presentations are known with NTM. The problem in NTM is difficulty in diagnosis, but you have to suspect them whenever we see that scenario which I have spoken about. When you get a sheets of AFB, when you get a gene expert negative, it is a clue that it is a non-tuberculous mycobacteria. So you have to pursue them with cultures. The cultures may take time. If you are lucky with rapid growers, you may get early reports, but in general, the other growth of other organisms can go up to 6 weeks time. So that is the problem in diagnosing and treating. Then again, about treatment protocol, there is not much standardized guidelines available because the numbers are very less. We may have to choose a regimen according to availability, toxicity profile, comorbidities, and so on. And the duration of treatment is another problem that we will discuss later on. So coming to reports from India, so this is the series from CMC Vellore, which is reported in this year in Indian Journal of Transplant. You can see they have said around 1,700 transplants in the last 10 years. They could pick up only 3 non-tuberculous mycobacteria, of which 2 are Fortutium and 1 is abscessus. So the prevalence appears to be very less even in our population. So the reported incidence is 0.1 to 0.3%. As I mentioned, diagnosis is very challenging because of non-specific clinical manifestation. The most important clue is the AFB positivity and gene expert negativity. And as I said many times, it requires a combination therapy with various drugs. So that is the third admission. I think the fourth one, again, he presented in 1 month down the line with fever and productive cough, HRCT showing very ill-defined GGOs, AFB was negative, Gram stain showed GNB, sputum culture showed carbapenem resistance. These are all problems when you remain in hospital for long. These are all hospital-acquired infections. He was treated with ceftazidime avibactam aztreonam combination, clinical improvement within 2 days. He was very reluctant to remain in hospital and he was kind of said no to for further investigation. So we did not proceed further and he settled. That is why it went like that. Then again, another 2 months down the line, he again came with fever on and off for 2 days, shock requiring inotrope support, blood culture showing 2 bugs, graft dysfunction. Again, he was not very keen on getting a CT imaging done. This is the culture report. We can see the E. coli, NDM E. coli, and Enterococcus. This Enterococcus again found to have vancomycin resistant Enterococci. Again, this is the most troublesome pathogen. So he was treated again with daptomycin and ceftazidime avibactam as per the guidance of infectious disease consultant. And that is the last admission. This is in November 2024, presented again with large loose stools. Again, local examination showed a big collection just above the graft site. You can see the MRI picture showing the collection there. So this is the saying, it's the cricket analogy we use. It's not over till it is over. So we thought we have successfully conquered most of the pathogens, but still he came again with that collection. The collection was aspirated. Again, it showed Mycobacterium abscessus. So when we told the surgeons to remove the collection, they were reluctant. The interventional radiologist, so we sought the help of interventional radiologist who did an ultrasound guided aspiration and put aspirate most of the contents. Again, culture showed same NTM. This time we have sent the sample for culture elsewhere because very difficult to get a facility where you can do a NTM culture. Drain was also placed. So coming to the drugs that can be used in Mycobacterium abscessus infection, it can be used, the drugs commonly used are amikacin, imipenem, tigecycline, macrolides, and linezolid tedizolide. So these are the common drugs that are used in Mycobacterium abscessus. So what did we do? Again, we did a pick line, started using a combination of these 5 drugs as per our ID guidelines. The immunosuppression, most of them are withheld. It was just a 0.5 milligram of Advagraph that was going on with 5 milligram steroid. All other things were withdrawn. But he continued to maintain reasonable graft function. TAC and steroid, as I told, it continued. He had a terrible time there with massive CGI. Sometimes he was kept on parenteral nutrition for some time. He continued to require transfusions. I think he required around 4 units of leukodepleted blood over long period of time during this period. But the end was good. This is the important thing, the message. So this patient was followed up almost like he was treated with amikacin and imipenem for almost 3 months. Amikacin dose that were used was 750 milligram thrice a week as per our ID consultation. Imipenem was continued for 3 months. Thereafter, they continued all the oral drugs for another 3 more months. The wound started healing well. Repeat CT did not show any further collection. And surprisingly, in the next 10 months, there was no admission at all. And his creatinine remained 1.35. He was at lowest immunosuppression. That is the surprising point. So why I did choose to present this case? The peculiarities you can see, he is a non-diabetic. I really don't know why he had so much of infection. He had a pre-transplant tuberculosis. He was just induced with basiliximab. He was not even given thymoglobulin or other polyclonals. He developed multiple post-transplant infections from ESBL to Pseudomonas to cryptosporidiosis to esophageal to invasive CMV to NTM. He was maintained with minimum immunosuppression. He had no rejection despite HLA mismatch and so much of less immunosuppression. He reduced totally 6 units of leukodepleted products, long exposure to amikacin, but still maintained a reasonable graft function. So what remains unanswered in seeing this patient is I don't know why he was prone to get many infections. We did ask all our immunologists to look at immunoglobulin profile and all that. It was not it was normal only. Complement was also normal. So I really don't know what further we can do so that we can at least prevent him from developing further infections. So that remains still unanswered. So with that, thank you so much for your attention. I think I have to acknowledge the help of our microbiologist, our infectious disease consultant, critical care fellows, my own colleagues for the care. And the good thing is we could be able to bring him out despite all this. Thank you so much for your attention.
Thank you, Dr. Ram, for your exciting presentation. I must be having a torrid times, but we have enjoyed your presentation, but not but not you when you are managing when we are managing the patient, because he had a very torrid time. Luckily, this is very, very peculiar that he is a single HLA match, and he didn't receive any basiliximab induction, and still having a withdrawn immunosuppression, and still having a good graft in spite of a lot of ordeals of subsequent infections. Many congratulations for you for perseverance and treating the patient well, and it was a happy ending. And let me call upon Dr. Edwin sir to have your comments on this presentation and your insights.
Yeah, Ram, that was fantastic. I cannot imagine myself in such a situation, even in our hospital. And I know it would have cost a fortune for the patient, but they trusted you, and at the end, everything came out well. My observations are the initial TAC level was quite high, 30 nanograms. Probably that is one point that triggered off the entire thing. Second, of course, I'm sure the TAC level was optimized with the TAC dose was optimized with the levels. Number two, you mentioned about the cryptococcal being detected on the biopsy. Cryptosporidium. Most of our times, our microbiologists pick it up on the stool itself. And our experience is generally they do well with a short course of nitazoxanide. Number three, the multiple infections that he has had indicates only that the net immunosuppression has been high. A few years back, we wrote an article in the IJT, the link I have given in the chat box, about how to modulate immunosuppression during infections. So we go to the extent of saying at some point you can even stop the immunosuppression, allow the infection to get treated, and then restart gradually. Even that's not a bad idea, because with somebody, even if you go down on the MMF and go to AZA also has got its own problems, especially leukopenia, again predisposing to infection. The fourth point is our recent work on the toctinovirus PCR that we presented to the Southern chapter, and my PG Dr. Aruna got the Best Young Investigator Award for that. Probably if that is validated, we are trying to validate that PCR by King's Institute. So if the TTB PCR in over immunosuppression, the immune cells are less. So the TTB titers can be high. And if the TTB titers are high, then there's a higher incidence of infection and lower risk of rejection. While the patient is under immunosuppressed, the immune cells are high, low TTB titers, which means low incidence of infection and higher risk of rejection. Probably this would be the only sort of biomarker, if I can call it, that could probably predict which way the patient is going to go to. And amidst all this and the number of drugs that you've given, the graft function has been quite stable. And we don't see this much of infection with basiliximab. There are a lot of unanswered questions. I only hope that it doesn't develop any further infection. You've already had a huge load of infections in him. And name it, and we have seen a non-tuberculous mycobacteria with MMC. This is something to be kept in mind. Well done to entire team, especially the support teams, IDs, the microbiologists, and the patient for trusting you. And all is well that ends well.
Thank you, sir. Dr. Shyam?
Yeah. So, I would first congratulate you. You managed the patient despite so much of infections, and result was good. So, my observation, what I do in patient with multiple infections, so it shows, as Dr. Edwin has pointed out, the patient was over immunosuppressed. I could not see the TAC levels, but if there are recurrent infections, so probably I would take anti-metabolite completely off in this sort of patient and give the time to recover, because many of these infections are opportunistic. If you see cryptosporidium, you see CMV infection, many of then there is a sequel. Patient came to hospital because of the opportunistic infection, and then he developed hospital acquired infection, and that is why this chain keeps on going. So that would be my approach for these sort of patient too. And once the patient start getting better, no infection for some period of time, then you gradually introduce the 3 drugs, because the 2 drugs are usually sufficient in such patients. Secondly, regarding, again coming back to the cryptosporidium, nowadays you can do this because we have seen the sensitivity of the routine stool testing is not high, and you can miss many of these patients who have this cryptosporidium infection. So you can do this molecular testing. We do this biofiber or rapid GI panel, where you can actually detect these organisms more commonly. So that would be some of the points. So we usually will take anti-metabolite off and keep the TAC level on the lower side, and once the patient immune status is better, then gradually reintroduce to prevent recurrent reinfection.
Just a clarification regarding immunosuppression. So we have not used antimetabolite at all in that first 1 year fully. That is why I'm saying he has some genetic or whatever problem. I don't know why he's developed that infection. After he came to us, he was only on and long-acting tacrolimus of 0.5 milligram once daily. We are scared to reintroduce because he kept on getting infections. The 3 drugs were started only after declaring cure from NTM. That too also after 3 months only. That is why I am surprised why he is not rejecting. What is happening to his immune system? He was never on triple immunosuppression with us, except for the last 3 months. That too, only last 3 months he's on triple immunosuppression. So azathioprine we attempted once. That also he had pancytopenia, so we stopped. Maybe a few days only he would have got azathioprine. That is what I thought is very interesting in this patient. We in fact wanted to just do some genetic testing to pick up something odd. So we went to that level, but unfortunately we couldn't pick up anything. That's why we thought we will present in this forum so that anybody had such a similar experience. At one end, the patient developing repeated infections, whereas not much of immunosuppression, and he is able to pull along with this amount of immunosuppression only.
What actually saved him was the fact that he did not develop any pulmonary infection. Because if he's developed a pulmonary infection, then survival would have been very difficult. Some of the infections were all around the skin and the soft tissue and the gut. Just imagine if a pneumonia, we all have had bad experiences with pneumonias.
Well, such kind of infection also, he came twice with gasping and hypotension shock and also.
That is only sepsis and septic shock.
Septic shock.
But somehow he escaped from the lung infection, and I hope he doesn't develop one.
Okay, so I think we are exceeding our time actually.
Yeah.
Thanks for the wonderful discussion. I've seen a lot of questions through the chat box. I think we can answer in the thing. And without wasting much of time, we can go for the second presentation actually. Thank you, Dr. Ram, for your presentation. And Dr. Dhananjay, can you share your slides, please?
Yeah. I hope my slides are visible.
Yeah. Go ahead, please.
Yeah. Greetings from Hyderabad. After this mind-boggling case presentation, I'll be presenting a simple case of donors with hepatitis B and transplanting them into a hepatitis B negative recipients. Is it a chance or a threat? Slide is not moving.
Yeah, it's not moving.
Yeah. I'm just seeing. I'll just share it again.
Yeah. Yeah. Go ahead.
Yeah.
Okay.
So this is the overview of my presentation. I'll be going through the case and then brief about the subject in presentation. It's not moving again, sorry. Okay. So this is an overview of my presentation. I'll be speaking in brief about my case, followed by introduction. What is the impact of hepatitis B infection on the transplant? What are the screening tests we use? And what is the role of immunity and immunization in these patients? And how do we monitor these patients? So coming to my case, what is happening? Sorry. Just a minute, I'll just close it and present it again.
Don't make it as a full screen. First, try to see the slides are moving in your presentation mode. Then we can change into that full screen mode.
It's moving in my this thing.
Please share your slides.
Yeah. It's not happening. Just a minute. Sorry. I'll just exit and log in again.
Tom, in the meantime, you can have some questions to take from the chat box, like how to go about prophylaxis versus preemptive valganciclovir for CMV. Another one question is like, with so much of infections, can you look for CD4 and CD8 ratio? Any comments from the panelists? Or?
So I have actually written that they have talked about over immunosuppression, change MMF to azathioprine. So I have clarified that we have only used azathioprine following that cryptosporidial diarrheal episode alone. Thereafter, we couldn't use anything except low dose tacrolimus. Even that has been stopped whenever he had shock, hypotension, requiring ICU care. Only steroid was continued. BKV has been tested twice in urine and serum. That was negative only. Regarding CD4, CD8, honestly, we have not done. We have done a immunoglobulin profiling with IgG, IgM assay. That is after everything settled down. That actually shows it is normal. It's not answer. Answered, I'm not sure. Any other question which is remains unanswered?
Answered almost all. Dr. Dhananjay, is he here? Has he joined? Tangapandi? Just call him. Apologies for the interruption. I'm just trying to contact Dr. Dhananjay. Dr. Dhananjay?
Yeah, can you see me now? Can you?
Yeah. Just
The slides are not moving. Something is happening. Yeah.
first go. Yeah, go ahead.
So
Just cross that slide, that case presentation slide that is hanging on that slides only. Just you can skip that. Yeah. You go ahead, please.
So this is a 34-year-old male, a farmer, sole breadwinner of the family. Blood group was O positive. He's a diabetic, diagnosed 7 years back. Hypertension, presumed CKD, secondary to diabetic nephropathy. Slowly he reached end-stage renal disease. We had completed his vaccination status. He had multiple access failures. He was on right internal jugular vein permanent catheter. He had multiple ICU admissions for episodes of pulmonary edema. There was no sensitizing events, no history of blood transfusions. His native urine output was around 500 ml.
Hello.
Coming
Hello.
to details, we had an in-house cadaver which was around 25-year-old male. Unfortunately, met with a road traffic accident. He underwent a right frontotemporal craniotomy but could not survive. And when the family consented for donation, he was incidentally found to be HBsAg positive. This is the donor investigations. We can see here is hepatitis B viral levels were 18,300 international units. His HBeAg was negative, anti-HBeAg was positive. His SGOT, SGPOT were mildly deranged. His total bilirubin was 1.7. So there were no other donors. This patient, when we discussed with him, he consented for accepting the kidney because he was not doing well on dialysis. So we had some discussion among ourselves. Is it ethical to do so? What is the risk of this patient getting hepatitis B? Is there any risk of this patient having hepatitis or liver failure? In what ways we can prevent this infection? What should be our immunosuppressive strategy? All these came to our mind, and what is the effect on graft and what is the effect on patient survival. So these are the things which we came to our mind when we went through this. So we did some literature search, and since we knew that previously such transplants have been carried out, and after the literature search, we went ahead with the transplant. This is the transplant perioperative details. Patient's cross match was negative. We usually do Liminex lysate assay in a cadaver transplant. Is recipient HIV, HBsAg, HCV all are negative. Gastroenterology consultation was done because the patient has hepatitis B positive. His anti-HBs antibodies, which had been recently checked, was 84.3. He was preoperatively, he was administered one more dose of hepatitis B vaccine, and intraoperatively during the transplant surgery, he was given hepatitis immunoglobulin of 400 international units. We have also given a prophylaxis of 1 milligram of entecavir. we stick to the standard immunosuppression. Since it was a high-risk cadaver transplant, we went ahead with ATG induction and standard triple immunosuppression. So he was discharged. This transplant was done 3 years back. This patient was discharged after 10 days with a creatinine of 0.9. This patient now has completed 2.5 years of follow-up with us. His serum creatinine is somewhere around 1.2 to 1.3, and his all serological status as well as HBV DNA status till now is negative. So we discharged him with the advice of repeating HBsAg after 6 weeks, and then every monthly we asked to do a family HBsAg screening, and we vaccinated his wife, and we did a OPD follow-up of this patient. Now coming to the subject proper, whether we can do this transplant, we all know transplant is the preferred treatment modality of end-stage renal disease patients. The biggest challenge for undertaking kidney transplants or for any solid organ transplant for that matter is the availability of organs. Hence, we are always, as nephrologists, are looking to expand the donor pool by utilizing organs from extended donor criteria organs. Hepatitis B positive organs do fall under one such category. Sorry, again the slide. Is fall under one such category, and we know by various epidemiological studies that the prevalence of chronic hepatitis B infection is around 1.5 to 4% in Southeast Asia. When we consider our huge population, this amount of high prevalence will result in significant of number of donors, because the donors will come from this general population. So discarding such organs and not using them will harm the donor pool. The challenge is to determine the optimal use of kidneys from such donors, and best utilization may involve allocating such kidneys to transplant candidates at low risk of donor transmitted infections. We have multiple prophylactic therapies now available, which further eliminates the risk of this infection. Now, what is the impact of HBV infection on this transplant? We know there is more, if the patients have underlying CLD or cirrhosis, there may be more frequent and rapid progression to cirrhosis and development of hepatocellular carcinoma in these recipients, which can lead to high mortality. And also sometimes HBV post-transplant may cause de novo membranous glomerulonephritis, which can decrease the lifespan of these patients. And what about the impact of transplant and HBV? We do use high induction agents as well as higher immunosuppressive agents. Both innate as well as adaptive immunity is very crucial for HBV control, and immunosuppression in solid organ transplant can alter the disease course. Especially, it is seen that B-cell depleting agents like rituximab result in hepatitis B virus reactivation. So how do we screen the donors for hepatitis B virus infection? We use a panel of serologic tests like HBsAg, anti-HBC, HBeAg and anti-HBeAg, anti-HBs antibodies, and now newer techniques of DNA PCR techniques. So how do we interpret them? If the donor is HBs antibody positive, but he is negative for core antibody, HBs antibody, and HBV NAT, such person is a vaccinated person, and the risk of occurring in transplant is almost none. If the patient is HBsAg positive and HBC antibody positive, he is having a natural immunity in him also, there is no risk of infection which is transmitting to the recipient. Whereas what we are interested is in the next two category of the patients, where there will be core antibody positive and HBs surface antigen positive. Such patient is infected, he has low level of viremia, and some amount of transmission risk is expected in these patients. If there is core antibody is positive, HBsAg is also positive, and HBV NAT is positive, such patients are infected as well as they are in the replicative phase, and they have very high risk of transmission. These are the two special category of patients which will put our recipients under high risk of transmission and further risk. So we do use a multiple panel of tests. There are some limitations of using only serological markers because some of the infections, since they have a long window period, may miss, and there is lack of sensitivity, and there is rising concern for misclassifying these patients as low risk patients. Also, if you do an HBV DNA PCR, all clinicians will be much more confident in taking up these patients. But in a deceased donor setup, doing nucleic acid amplification test is an optional test, and also it comes with certain disadvantages, like it has certain cost involved with it. There are logistic challenges in getting this time test at odd hours like at night, and it has a long turnaround time of minimum 8 hours. So whenever we encounter such a donor, first is thorough complete initial evaluation of the recipient should be done. Recipient should be looked for symptoms and signs of cirrhosis, as well as alcohol intake and metabolic risk factors and family history of HCC, which puts him at a high risk of having chronic liver disease. All routine lab tests, including CBC, platelet count, all liver function tests, and these should be done along with the serological markers of HBV DNA in him also, and also to, if the patient has high risk behavior, we should do HCV, HIV, all these things. Depending upon the serological markers, we can divide the donor into either anti-HBC positive and HBsAg positive patients. Categorizing the donor into these two categories will help us in risk stratification, and will also help us to optimize the risk, optimize the immunosuppression as well as the medication. So anti-HBC positive patients, so anti-HBC positives usually has a very low risk for converting into or transmitting risk into the recipients. This is a very big study which looked at such positive donors. Around 3,385 donors were studied in this study. In them, only 45 subjects showed seroconversion of HBV markers, and the total rate of seroconversion was calculated around 3.2%. It is to be noted that this is only a seroconversion. It does not mean that such recipients develop clinical disease. Hepatitis B surface antigen positive donors are the key factors to consider, because HBV transmission remains a challenging problem in these patients, and previously we used to discard these organs. But in the current era, with the newer molecules available, especially antivirals, and also we have lot of data available, interesting information regarding the use of these kidney donors. So the reports which appeared showed that some of the recipients developed fulminant hepatitis B when they received kidneys from HBsAg positive donors, but it is noted that these patients also had high amount of HBeAg positivity. Since this report, HBeAg and anti-HBe are routinely checked in HBsAg positive donors. This is to ensure a low infectivity. If the patient is HBeAg positive and high levels of virus is documented in the HBV DNA test, such patients are not good donors, and it is very important how to decide how to proceed for transplant when considering these donors. Thus, other studies looked at considering patients who are immunized with hepatitis B vaccines. In such patients, this study looked at HBsAg negative recipient who had anti-HBs titers above 100 international units. So in those patients, if they received kidney from HBsAg positive donors, there was no significant difference in graft and patient survival. Most important is this study did not use make use of any antiviral prophylaxis also. So those patients who have higher antibody titers which are protecting them, in such patients we can safely go ahead for the transplant, especially, and they do not even require antiviral prophylaxis. So subsequent authors looked at, subsequent authors looked at taking HBsAg positive donors and transplanting into them recipients who had lower titers of immunoglobulins level in them. So this study looked at those patients who had anti-HBs titers more than 10 milli-international units. They reported excellent outcomes of transplanting theirs, and they did not notice any graft as well as patient survival in those who had protective levels more than 10 international units. So this is another study which looked at live transplant. So live kidney transplants were retrospectively seen, and before them 28% of the donors had HPV DNA positivity, and the results showed that those patients who had good amount of HBs protection had excellent graft and patient survival. So what is the take-home message is, in principle, the recipients who received kidneys from donors with hepatitis B should have protective antibodies. Several guidelines have suggested that an anti-HBs more than 10 is protective, and it is important to note that HPV transmission may not always lead to clinical evidence of HPV infection. So these are the various articles which have looked at the level of immunity and how to immunize such patients. So American Association suggests periodic assessment of these patients for monitoring of these patients with ALT, SGPT, as well as HPV DNA and anti-HBs during immunosuppressive therapy. They allow us to monitor the liver enzymes and HBV DNA every 3 months for at least 12 months for post-transplant. So how do we define whether the hepatitis B is transmitted to the individual? So this is based on several serological as well as virological profile. If the HBV DNA is more than 100 international units, or if there is a more than 2 log increase in the HBV DNA from the baseline, or if the patient was either to HBsAg negative and he has turned HBsAg positive, then it is considered serological recurrence or serological transmission. So this is another study which looked at around 449 HBsAg negative patients who were analyzed for HBs reactivation. In these patients, the reactivation rate was around 2%. So anti-HBs plays a key role to minimize the risk of HBV transmission, and hepatitis B vaccination should always be given to naive recipients as well as to previously immune recipients who have anti-HBs concentration below less than 10 international units. So this is the vaccination protocol of 4 doses which we follow in our dialysis patients. We should know that we should not take it for granted and check HBs levels, because at least 30% of our dialysis patients will not be successfully immunized even when we use double the dose. So there is a significant debate which titers are very protective. Some of the studies say that anti-HBs should be kept more than 100, and some studies show that it should be more than 100, now more than 10. So now coming to the prophylactic strategy, whether we should use antiviral to each of these patients. Some of the studies have adopted what is known as prophylactic strategy and have administered universally antiviral agents to all the patients, whereas in some preemptive approach, they have used PCR assay to detect HPV DNA, and in those where there is a serological recurrence, in such patients only they have used antivirals. We have various antivirals at our disposal: lamivudine, entecavir, adefovir, tenofovir. Among them, most commonly used are entecavir and tenofovir. So the most renal transplant experience is with lamivudine, because they are the earlier studies. But entecavir is the most potent agent, and tenofovir is also an acceptable alternative, especially in patients with lamivudine resistance. Now coming to what is the role of hepatitis B immunoglobulin in such patients. Some studies have used hepatitis B immunoglobulin in addition to antiviral therapy in select group of patients to provide passive immunity. The amount that has been used is around 600 to 2000 international units, and they have used one or multiple doses in the first 5 days of kidney transplantation. So it is also advised to keep the immunosuppression at a minimum level in these patients, the level which to prevent rejection. It is the steroids and the rituximabs which are at a high propensity to cause the risk of reactivation of hepatitis B. Hence, it is advisable to taper the prednisolone to less than 5 milligram daily, and wherever we are using anti-rejection therapy and rituximab, to do more frequent follow-up of such patients. So this is a flow chart which shows the risk factors and the protective factors which I have highlighted. The crux of the study is, or the take-home study is this slide. If the patient is HBeAg positive and HBV DNA positive in high titers, such patients, it's better to discard because there are risks of developing fulminant hepatitis B when we use high induction agents and high risk of high immunosuppression in such patient. If the HBeAg is negative and HBV DNA is positive, if the patient is not vaccinated or a naive patient, it should be used only in patients with life-threatening conditions, and nucleotides should be used in them for 6 to 12 months, and along that, better to use hepatitis B immunoglobulin. If the patient is HBeAg negative and HBV DNA negative, in such patients, if the anti-HBs is at least 10 international units, we can add nucleotide analogs of around 6 to 12 months. There is no need to use hepatitis B immunoglobulin in such patients. If the patient has anti-HBs more than 100 international units, in such patients also, we can optionally use the antiviral agents for 3 to 6 months. But in all these patients, it is compulsory to do a monitoring of HBsAg, HBV DNA, and liver function test every 3 months for the 1 year. Then whenever we are giving anti-rejection therapy, again such patients should be kept under monitoring. So the take-home message from my simple presentation is optimal use of hepatitis B positive donors is possible. Hepatitis B DNA PCR technique is becoming a useful screening test for risk stratification and recipient allotment. FB core antibody positive donors have a very low risk of transmission and they can be accepted very safely. Among the HBsAg positive donors, anti-HBs titers play a key role to minimize the risk of transmission. So regular monitoring schedule for these patients as well as immunizing these patients is very important. Thank you.
Thank you, Dr. Dhananjay, for your crisp and nice presentation, and congratulations to you to have a gut of doing a hepatitis B positive donor to negative recipient. And hope the patient is doing well, and thank you for your presentation. And Dr. Edwin sir, can you have your comments, please? Shyam, Dr. Shyam, your comments, please.
No, I actually agree with whatever points Dhananjay has made. I think it's important to know these limitations, and then you can optimally use some of these donors in the recipient who are well protected, and then follow these guidelines. So I think we have also used at least 2 donors who were hepatitis B positive, and those recipient had good anti-HBs titers in those patients only in the living transplant, and both of them, they are doing well. So
The same protocol followed. That means that core antibody is positive and HB negative antigen is negative.
yeah. And second important, because in the living this thing, it's the anti-HBs titer. So we have used both the recipient who were anti-HBs titer were adequate, means it was more than 100 in both of our patients. So The important thing, if you encounter such a donor, then it's important for the dialysis patients and our patient to vaccinate for hepatitis B, and then obviously to check their levels to see they are properly immunized or not, so that if there is no option, then you can use some of these donors.
Okay. I think we are exceeding our time, and there is one more question. Can we adopt this for living donor transplant? And as Dr. Shyam told, that we can adopt the same criteria for living donor donation also. I think there is no, does specific HPV DNA viral load above, which is considered treatment? Is there any cutoff for HPV DNA viral load?
HPV,
Yeah, so for the living, I would wait, because this was a deceased donor. For the living, unless it's become viral load is very low or undetectable, I would wait for the transplantation. No, it's just a carrier. Patient is just not at VE positive, and DNA load is less. Means it's less than 200 copies or like that. Then only, and that too when the recipient is vaccinated with good antibody titer. So you'll not hurry in the case of living donor, at least.
Okay. No, I don't think so. Any other chat box questions? And it was a remarkable session this month. Actually, we had a good presentation with the Dr. Ram presented the multiple infectious episodes, and we learned from that cumulative immunosuppression is more important. And dose of immunosuppression is very important to take care of when you have a patient with post-transplant infections. And still, it's very tricky, and it is unknown. Some patients do well with completely stoppage of immunosuppression. Some patients don't do well with this suppression also. So ultimate point is that immunosuppression is more important, and we learned a lot from him regarding the non-tuberculous mycobacterium, non-NTM treatment of NTM and all. And second part of presentation with Dhananjay, that HBs positive to HBs negative, and we learned a few good points regarding the things to be looked for when you do such kind of transplant. Overall, it is a good eye-opener and many take-home messages from this meeting. And once again, I thank the speakers who had a painstaking effort to prepare the slides and present to us. And I thank the panelists for their insights and inputs, and the participants who have been in the unwavering support for the past 4.5 years to continue this program. And thank you very much, one and all, and I must thank the MQ team for giving the technical support, and invite the other institutions to come up with the cases to present every month, so that we can learn from each other to make this meeting a successful and fruitful one. Thank you, one and all, for joining us for this meet. Thank you. Thank you, Dr. Shyam and Dr. Edwin sir, and the panel speakers. Thank you.
Thank you, Rajan. Thank you for the opportunity. Yeah.
Thank you, sir. Thank you.